Thank you. Um, so over the next few minutes, I'll try to explain to you the use of FFR in left main. So specifically, I would like to focus on two things. That is the pre-PCI FFR for deciding on left main significance and post-PCI FFR for deciding on circumflex or side branch intervention. So left main supplies around over 50 to 75% of myocardium in most of the people, and disease is found in 7% of the angiograms. Medically managed patients has 50% mortality if it is significant, and the problem is even after revascularization, left main patients have 20% event rates. That's the data from Excel. The consequence of plaque rupture is quite catastrophic, and 50% of left main angiograms are wrongly assessed by experienced cardiologists. So most of us teach our residents that one of the dangerous thing is to say that coronary angiogram is normal. So many times you have come across this problem. They will report a coronary angiogram absolutely normal, and later we will find that patient is having angina, and careful look at the angiogram, you will find that left main is abnormal. So IVUS is considered as a perfect solution, but the problem is a person who is 6 feet tall and 100 kilograms and a frail old lady with 40 kilograms may not have the 6 millimeter cutoff that is used for the IVUS. So the classical teaching is MLA of more than 6 is defer, and less than 6 we should revascularize, but that is recently modified to less than 4.5 you should definitely revascularize, and 4.5 to 6 we should assess the physiology. So why is it that? So the thing is, the classical teaching about MLA about 6 has recently been in 2011 evaluation with FFR. It has been found out that MLA of 6 equates to much lower FFR, and if you look at the FFR of 0.80, then the cutoff becomes 4.8 millimeter square. So because of this, we need to take it with a pinch of salt, the values less than 6. And question is FFR useful in assessment of ambiguous left main disease? Because left main disease was an exclusion criteria for most of the major trials in FFR. Question is, can you defer revascularization if left main FFR is more than 0.8? The large meta-analysis in which more than 500 patients were included, published in 2015, gave the answer that if you defer, the survival in the defer group also was not different from the patients who was revascularized. This included 540 patients with a follow-up of about 30 months. So it can be used, but there are no large-scale trial results available as of today. We are hoping to have those results in the near future. So the answer is yes, but what about IFR? Are there any evidence for using IFR for evaluating left main? So this was the first study in which it is an observational study in which 314 patients who had left main stenosis, based on the cutoff value of IFR of 0.89, 163 were deferred and 151 was revascularized. And the major adverse cardiac events at 50 months did not differ in between the groups. So we can safely consider that deferral with a IFR value of more than 0.89 is safe. And this is another study which showed that if the IFR is 0.89, it correlates with the IVUS ultrasound value, IVUS value of lumen area of less than 6 millimeters square, irrespective of the body surface area. So this is another evidence that it could be equivalent. So the technical precautions that has to be followed, all of us know, but just to revise that, guiding catheter should not have side hole, preferably use 6 French for FFR. Avoid extra backup, preferably use JL because it might impinge on the wall. And keep guiding catheter away from the ostium throughout the measurement. and avoid damping ventricularization, and always use an aortic root guide wire, and equalize the guiding catheter inside the guiding catheter or aortic root, because left main assessment is a little bit different from the others. Adenosine route is only intravenous, and it should be in central line. And the problem with guiding catheter is also compounded in left main assessment, because if you use a too large a guiding catheter, you can have the guiding catheter itself causing a false positivity. And then if the guiding catheter gets engaged, you can have a false negative value, like what you're seeing here. And if the true FFR is 0.68, and if you engage it deeply, you will have ventricularization, and the falsely high value will come. And this is very important, that sepal wire or buddy wire should be placed in the aortic root to ensure that the guiding does not get sucked in during the hyperemia phase. Now coming to the different scenarios. This is 5 scenarios are there. Isolated left main with RCA total or severe, left main with LAD or LCX lesion, and both LAD and LCX lesions. So what is the effect of an LAD lesion in intermediate left main FFR? So if isolated left main, the FFR is 0.78. Once you have a LAD lesion, the value goes high. That means you will have a false negative value. So presence of a LAD lesion will increase the FFR value in left main if you have a left main lesion. So this you have to be very careful about. What about right coronary artery lesion? Suppose the patients had only left main lesion with no RCA lesion or LAD or LCX lesion. If the FFR is 0.82, if the person has a RCA lesion or RCA total lesion, very tight lesion or total lesion, then it will be a false positive. That means total occlusion right coronary artery will decrease the FFR value in left main. So there are 3 terms that you have to be careful regarding FFR in left main. That is FFR true, FFR apparent, and FFR epicardial. So this is the principle. FFR true means the actual, in the absence of any lesion in circumflex or LAD, if the FFR apparent is in the presence of an additional lesion, you have a abnormally high value, and FFR epicardial is across the 2 lesions, left main and LAD lesion. If you put a wire, then the value that you get is the FFR epicardial. So these 3 terms you have to remember when you are dealing with multivessel disease with left main disease. So basic problem here is maximal hyperemia is possible only when the downstream disease has been treated. So if some situation like that happens, we need to ensure that the distal lesion is treated, and then we check again. So what are the steps of evaluating this? First, measure the FFR in the least diseased vessel, preferably LAD with pullback. If FFR is more than 0.85, defer and treat medically. If FFR is less than 0.80, left main is significant and need revascularization. FFR between these 2 values and there is a significant downstream disease, measure the FFR in diseased vessel, and FFR epi is less than 0.60, then stent and repeat left main FFR. If it is between these 2, assess left main by IVUS. So this is the comparison of IFR and FFR for left main. FFR, there are this meta-analysis, there are a lot of studies are there. IFR, the studies are only coming in, but the biggest advantage is that you don't have to use adenosine, and that becomes quite significantly better for left main. So this chart I will just skip. I'll come to the conclusion. So this is the side branch actually. So normally when you have a non-diseased circumflex, after stenting, if you have a lesion like this, what do? Most of us will go ahead and put additional stents and kissing and crush and everything. But you can see this, if the FFR is normal at the baseline, even at the end of 8 months, it is going to be normal. So another study, so FFR should be used for side branch assessment in left main PCI, and we should put only stent in the side branch, that is LCX, only if it is significantly abnormal. So this 5-year result shows that it is safe to defer even if it is looking pinched, but FFR is normal. So the take home messages are, FFR is the ideal first choice in assessing intermediate left main lesions. Technical tips has to be carefully looked at. Isolated left main disease differ if IFR is more than 0.89 and FFR is more than 0.80. left main and associated lesions, RCA total, revascularize RCA before doing left main FFR, or differ if IVUS ML is more than 6. Circumflex and LAD associated disease, keep wire in the vessel without disease. Less than 0.8 left main significant, more than 0.85 left main not significant. Look for epicardial FFR of less than 0.6, and IVUS assistance can be used. Use IVUS in ACS. ACS, you don't do all these things when the left main LAD or LCX is the culprit lesion. And post left main LAD stenting, always use FFR to decide on circumflex stent if it is looking pinched. So this is effective eyeballing. This I want to highlight because one of the commonest mistakes. 40% mismatch and 56% individual variability if you assess left main only by angiography. So we should start using FFR and IFR for most of our left main disease patients. Thank you.